CCR of Psychiatry. Today we are going to present two cases of catatonia. Catatonia is when the patient presents with a motor symptoms. It could be motor withdrawal or it could be motor excitement. It's increased motor activity, increased psychomotor activity. And such patients are not uncommon in clinical practice, and especially the motor withdrawal or the psychomotor withdrawal, and the person becomes completely mute, completely motionless, and these may end up in emergency, come in general medicine or pediatrics, depending on the age group. And we'll be discussing two unusual presentations of catatonia, which were referred to us from pediatrics or emergency. I'll request Dr. Vijit Batra to begin his presentation.
Thank you, sir. To start, that catatonia is a neuropsychiatric syndrome which is characterized by abnormal movements, speech and behaviors. That is a motor abnormalities that can be excessive movements or reduced mobility, or abnormal movements like repeated or stereotype movements, or mimicking the movements of others, or posturing, reduced or other abnormalities of speech, and negativism, that is senseless refusal to comply to the instruction, which can lead to reduced functioning, and reduced food intake or fluid intake can lead to poor general condition. This is the most commonly seen in medical and neurological disorder, and also can be seen in psychiatric disorder like mood disorders and psychotic disorders. So these are the symptoms like sitting very still and staring into space, holding unusual postures for a prolonged period of time, repeating non-goal directed activities, or repeating phrases, holding strange faces, not eating or drinking. So these are the symptoms of presentation, and this can be assessed by a scale known as Bush-Francis Catatonia Rating Scale, which is commonly used. This is a 23 item scale. Out of this 23, 14 items are screening questionnaire. So presence of two or more signs for more than 24 hours is called as the catatonia is present. So then coming to the catatonia in children and adolescents, the prevalence is found to be varied from studies to studies. Some study found is 17.8%, and one Indian study in inpatient setting found as 9.45%. Whereas in children and adolescents, the incidence was in very low, 0.16% per year, and another study found that 5.5% in 3 months period. So the presentation is almost similar in adult and children, like mutism, immobility or stupor, staring, and negativism. But catatonia secondary to general medical condition is seen more frequently in children and adolescent group, which is 15.4 as compared to 7.9% in adults. And neurodevelopmental disorder seen in more common, 3.8% in children and adolescent group, and none in the adult group. And the pervasive developmental disorder or autism spectrum disorder has been found to 81% case in some other studies, and excitation and agitation is also can be a common presentation in children and adolescent age group, and sometimes also it is associated with genetic syndrome and due to medication induced. So today in the presentation we will demonstrate two cases. That one case presented with a catatonia prolonged duration, severe form of illness with deterioration of general medical condition, and that required medical care associated with fever and incontinence, and the patient had history of delayed developmental milestones in past. And another case that presented with catatonia, that is improved with lorazepam and psychotropic medication without deterioration of general medical condition. So now I invite senior resident Dr. Ankesh to demonstrate the two cases. Thank you, sir. Good evening, everyone. I'm Dr. Ankesh. I'm a senior resident in the Department of Psychiatry. Demonstrating the first.
Closer to the mic or a bit louder?
Begin with the first case. The case is of Miss K, a 9 years old girl studying in class 4, belonging to a nuclear family of low middle socioeconomic status residing in Delhi. There were some positive findings in the personal history in the form of delayed cry at birth and delayed milestones. When she presented to us in the psychiatry OPD, uh, she had symptoms of minimal verbal output. She would refuse to eat and drink. She would sit in one place, in one position for 2 to 3 hours continuously. She would stare at one place without blinking for long periods of time. She would maintain rigid postures despite efforts to be moved. And there would be apparently motiveless resistance to any kind of instructions or attempts to move or examine her. She was admitted from the OPD to C1 ward in the child group. On examination, she was afebrile, her vitals were stable, there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. There were no signs of dehydration. She had an NG tube in and IV cannula in situ, and she was wearing a diaper. She was poorly groomed. She had a vacant facial expression, was sitting with arms and legs folded on the ground like a statue with eyes fixed and decreased blinking, was not following commands and was resisting being moved. Rigidity was present in all four limbs and trunk whenever she was being moved. There was resistance to passive limb movements, and the resistance was proportionate to the force which was applied. The Raspam challenge test was done, which was negative, and the rating scale score was of 20. I'll be presenting. Sir, in patients who present with catatonia, we see that when we give intravenous benzodiazepine, there is improvement in the catatonic symptoms. Sometimes it's miraculous in the sense that a patient who was so immobile and in a stupor state suddenly becomes very talkative. So we are able to many times diagnose that this is catatonia and not a different condition. Yes, sir. It's not always that. Presenting the history of her illness. Her illness began in September 2022 with complaints of sadness of mood, decreased interest in earlier pleasurable activities, decreased attention and concentration, crying spells, decreased social interactions, decreased sleep and appetite. Such symptoms were there for around 1 month. After 1 month, there was a sudden deterioration in the form of catatonic symptoms, which came like she was staring, she was maintaining one posture for hours at end. She would refuse to eat and drink. She would not talk. She would not follow any instructions. There was rigidity. She was not tending to her self-care. There was bowel and bladder incontinence. Such symptoms were there for 2 to 3 months in the month of October to December 2020. When she developed these catatonic symptoms, they sought help. They approached a medical college in Delhi, where she was admitted in the pediatrics ward at first, where she was medically managed, and then she was transferred to the psychiatry ward. In the psychiatry ward, while they managed the catatonic symptoms with medications, on treatment, there was a sudden change in the symptoms. In the form of she was very cheerful, there was increased energy, there was increased goal-directed activity, there was decreased need for sleep, over-talkativeness, over-familiarity, and over-demanding. During the month of January and April, when she was there in the hospital, when she was admitted in the psychiatry ward, in spite of treatment, she would keep having this fluctuating course of catatonic symptoms and the manic symptoms. It would alternate every 2 weeks, and in spite of treatment, it would not get better. Pediatrics consultation was sought in that medical college as well. They did a workup and they said that there was no organic cause which was found. They had ruled it. Now, different from the earlier symptomatology, this time when she had a manic episode in the form of cheerful mood,
increased energy, over-talkativeness, over-familiarity, and over-demanding. This time, the episode lasted for around 5 weeks in the month of May 2023. During the end of May, they approached AIIMS for treatment as she was not getting better in the medical college. She was seen in the OPD first and then later planned for admission in the child. She was admitted to C1 ward on 10th of June 2023. Now the ward course. During the first week of ward stay, lorazepam was being given for the catatonic symptoms. The dose was optimized to 8 milligrams per day. Along with that, we were giving olanzapine 5 milligram. We continued vitals monitoring and IO charting in view of her refusal to eat. Feeding was being through nasogastric tube, 200 ml every 3 hours, which was after taking consultation from the pediatrics team. We faced difficulty with obtaining blood samples and IV access. We needed repeated help for sampling from the pediatrics team and anesthesia team as well. And many times the patient would remove the NG tube as well. During the first week, the patient developed 101 degree fever. There were multiple fever spikes. She developed hypotension. Peripheries were cold. There were signs of dehydration, and an impression was made of very hypovolemic or septic shock. Pediatric consultation was taken. Fluid resuscitation was done using normal saline bolus of 20 ml per kg. Along with that, NG feeding was continued. Vitals monitoring and IO charting was further intensified. She was given antibiotics for the fever in the form of ceftriaxone and vancomycin parenterally. Lorazepam dose was decreased, keeping in mind the medical condition, and olanzapine was stopped. Fever workup was done. Multiple investigations were sent. In the second week, her catatonic symptoms were resolving, but fever persisted. Review was taken from the pediatrics team. Antibiotics were upgraded to meropenem and vancomycin. We continued our intensified vitals and IO charting. Plan was made to insert a central line in view of difficulty in obtaining peripheral IV access for fluids as well as the medications, as well as for blood sampling. Repeatedly, we had to change the site of IV cannulas due to development of thrombophlebitis. Pediatrics team asked for an autoimmune workup, and their plan was to give intravenous immunoglobulin. From our side, we got an MRI done, which showed no abnormalities, and EEG showed diffuse flowing. In the third week, fever persisted. Fever screening investigations were all negative. Antibiotics were upgraded further to teicoplanin and meropenem. In spite of that, fever persisted. Then the patient was transferred to pediatrics team, and a working diagnosis of autoimmune encephalitis was made. CSF studies found no biochemical or cellular abnormality. IVIG was given on 3 days. We sent CSF and serum autoimmune and paraneoplastic panel to NIMHANS, but the investigation came negative. Lorazepam at this time was at 4 mg and olanzapine at 5 mg. Catatonic symptoms were reducing gradually. But as the catatonic symptoms were improving, behavioral symptoms began to come into the picture in the form of irritability, crying spells, and at times running in the pediatrics ward. In the fourth week, the Catatonia rating scale was still 5, but behavioral symptoms continued to increase, and NG feeding was continued. The medication from pediatric stream was continued. From the pediatric side, they got a PET scan done which showed hypometabolic regions in basal ganglia and hypometabolic regions in the parieto-temporal region. An autoimmune workup was done in which some positive findings were there. ANA was positive, lupus anticoagulant was positive, DCT was 3+, and based on that and in clinical criteria of fever, a diagnosis was made of SLE. For that, medications were started in the form of methylprednisolone intravenous pulse, followed by oral prednisolone on maintenance. She was also started on hydroxychloroquine 100 mg per day and aspirin 75 mg per day. She received intravenous mycophenolate mofetil also 3 doses over 3 days, and for an immunotherapy with cyclophosphamide. Out of she was planned for 6 cycles, out of which she has received 4 till date. NG feeding was continued at 120 ml every 2 hours, and lorazepam was being decreased to 3 mg as the catatonic symptoms were improving, and olanzapine was still at 5. During in the fifth week, she was transferred back to psychiatry in view of increasing behavioral symptoms, increased activity, increased energy, irritability, and overtalkativeness. Her catatonia rating score was 0. Her catatonia had resolved, but the behavioral symptoms were there. Her mania rating scale score was 18. YMR is a young mania rating scale. Olanzapine was up titrated to 10 milligram in view of the behavioral symptoms. We also initiated valproate, and lorazepam, the taper of lorazepam was continued gradually. Hydroxychloroquine, aspirin, and prednisolone was continued as advised by the pediatrics team. We were encouraging oral feeding. Now she was accepting orally, but she was still refused to take medications, for which we had to continue the NG tube in situ, and all medications were given through the NG tube. If at times when she would remove the NG tube, we would miss some doses of medications as well. During the 10th to 12th week, her catatonia had resolved by then. Her behavioral symptoms, although they were persistent, they were reducing gradually. There was improvement in the behavioral symptoms. Olanzapine was cross-tapered with risperidone in view of poor response. Valproate was continued and optimized to 1200 milligram per day. And on this medication, over the next 2 weeks, there was improvement in the behavioral symptoms. She started to take her medications orally, and we electively removed the NG tube. Hydroxychloroquine and aspirin was continued. Cyclophosphamide 4th cycle has been completed. At the time of discharge, we have made a diagnosis of organic mood disorder with SLE. On discharge, we have given her medications of syrup risperidone, 4 milligram per day, syrup valproate 1200 milligram per day. Along with that, continuing the medication from pediatrics team. And from our side, plan is to conduct an IQ assessment on OPD basis after remission of manic symptoms, keeping in mind that there was history of delayed milestones and history of delayed cry. I would like to invite the faculty from pediatrics team if they could give their input. Thank you, sir.
So I think there are a couple of information which was missing in the presentation. But why we thought lupus in this child is a bit struggling, because in fact the first child was admitted in pediatric neurology and then to pediatric rheumatology once we have the possibility of lupus. So chiefly she has psychiatric manifestations, and then if I guess you're not sure the counts which were leukopenia, and there was, if I remember correctly, the DCT was positive, and there was history of oral ulcers and arthralgias on top of these neuropsychiatric manifestations. So if we look at the pediatric lupus, it is more I would say more aggressive as compared to adult lupus, and challenging neuropsychiatric lupus is again very difficult for two reasons. Number one, for example, if you have a renal lupus, you have access to urine RM or urine microscopy where you can see assess proteinuria. Or for example, if you have lupus myocarditis, you can go for echocardiography, look for low ejection fraction. Unfortunately, we don't have any such a sacrosanct tool for diagnosis neuropsychiatric lupus, and we have to bank on help of a psychiatry team how exactly to evaluate. We don't have an actual biomarker, though there is some studies which say that anti-P ribosomal antibody is raised or increased in those with neuropsychiatric lupus. And similar to the diagnosis, how it is challenging to make the diagnosis of neuropsychiatric lupus, the same is true for the management of neuropsychiatric lupus. If you look at the broad principles of management of lupus, there are no well-designed randomized controlled trial to guide the treatment of neuropsychiatric lupus, but broadly what we follow the principles of the end organ involvement, which means the most literature is from renal lupus, and we would treat this as an end organ wherein CNS or cardiac involvement or renal involvement, wherein you will consider using cyclophosphamide as an induction agent as has been used in this case, and then mycophenolate mofetil in the maintenance phase. So this is for the treatment, and probably of course the psychiatric part has been taken by this. So it has been a challenging case as far as the diagnosis is concerned, and the same is true for the management. Thanks.
Thank you, sir. Now, moving on to the second case. Master K, 15 years old boy studying in class 10, belonging to a Hindu nuclear family of low middle socioeconomic status. He was brought to the psychiatry OPD in AIIMS with symptoms of decreased verbal output, reduced oral intake, and instances of refusal to eat and drink, sitting in one place in one position for long periods of time continuously, staring at one place without blinking for long periods of time, maintaining rigid postures despite efforts to be moved, apparently motiveless resistance to instructions. He was again, like the previous patient, admitted from the OPD to C1 ward in the child unit. On examination, he was afebrile, vitals were stable. There was no pallor icterus cyanosis, clubbing, lymphadenopathy, or edema. No signs of dehydration. He was poorly groomed. There was a vacant facial expression. He was sitting on the bed with eyes fixed and decreased blinking. He was not following commands, was resisting being moved. Rigidity was present in all four limbs and trunk whenever he was being moved, and resistance was to passive limb movements was present. The patient's illness began in December 2022, wherein he had sudden onset change in behavior in the form of decreased appetite and sleep, decreased social interactions, fearfulness, suspiciousness, hallucinatory behavior, talking to self, mumbling to self, muttering to self. He was aggressive. He would keep staring at one place. There was decreased blink rate. There was rigidity in all four limbs. He would not obey. He would not follow commands. He would sit in one place for prolonged periods. Would not talk much, and would refuse to eat and drink. Such symptoms were persistent for a period of 1 month, after which there was a sudden change in behavior to over-talkativeness, over-familiarity, cheerfulness, elevated self-esteem, increased activity and energy, decreased need for sleep, increased planning, over-religiosity, and demanding behavior, which lasted for the next 2 to 3 weeks. Following this, again there was a sudden change in behavior, where it went to the previous symptomatology, where he was not interacting much, he was not eating much, refusing to eat and drink. He would stay in one place for long periods of time. He would be suspicious. He would talk to himself. He would laugh when he was alone. This episode lasted for the next 2 to 3 months. In April, he came to AIIMS in the OPD, and he was planned for admission in the ward in view of poor response to treatment on OPD basis due to poor compliance and diagnostic clarification. During the admission, he was started on treatment with lorazepam and olanzapine. As he was given the medication, the catatonic symptoms began to improve, but again there was sudden change to the different set of symptoms, which were again present earlier: over-talkativeness, over-familiarity, cheerfulness, elevated self-esteem, increased activity and energy, decreased need for sleep, increased appetite, increased planning and demanding behavior. Because of these symptoms, we also added valproate into the treatment regimen, and vitamin B12 was low, so for that we gave supplementation. On these medications, lorazepam, olanzapine and valproate, he improved and he did not have the complications which were there in the earlier first patient. This is the, I wanted to compare and contrast both the patients.
Thank you, Dr. Ankit. So some of the issues in challenging the catatonia in children and adolescents. Some symptoms are important, like psychomotor regression, and history of neurodevelopmental disorders are more frequent in children. And organic condition, like primary medical condition, that can be as high as 20% in some of the studies, and morbidity and mortalities are also high in child and adolescent age. And though lorazepam and ECTs are used frequently in adult population, there is a resistance against the use of ECT and high dose medication exists among clinicians, and the frequency of drug adverse effects are more in children and adolescent population. And when there is a new onset of presentation, first time when there is no history suggestive of any past psychiatric illness or no clinical signs and symptoms of any medical illness, it is difficult to diagnose whether there is a primary psychiatric illness or this is primary medical condition. Like in this case, the child when presented the first case, she did not have any symptom that suggestive of SLE, like malar, rash or other typical symptoms. So this is a challenge, and the necessity to manage family reactions and fears in case of children and adolescents, which is generally an obstruction in managing children and adolescents in psychiatric setting. So while assessment the Bush-Francis scale that was discussed, that is commonly used, but sometimes the social withdrawal that is applicable for the adults, that cannot be applicable for children, because some symptoms can be part of other disorder in children and adolescents, like social withdrawal can be a part of autism, and incontinence as a symptom of psychomotor regression is an important symptom in children and adolescents. And sometimes excessive incoherent talking and acrocyanosis is an indication of malignant catatonia in AIDS. So the management in general, to manage the general condition like NG tube feeding or adequate hydration by IV fluids, though IV catheter is usually avoided to avoid hospital acquired infection, and prevention of aspiration and thrombophlebitis prophylaxis. So among benzodiazepines, lorazepam is the first line of treatment, because the hypothesis shows that this top-down modulation of basal ganglia is due to deficiency of cortical GABA, which may explain the motor symptoms of catatonia, and the benzodiazepine increase the level of GABA, which causes the improvement. And ECD should be considered in catatonia, which is resistant to benzodiazepines, though it is more frequently used in adults as compared to children. In some studies also they found no ECT was used, but in a recent study that retrospective review over 10 years, they found that it is quite efficacious and safety in children and adolescents. Even as low as 10 years of a child received ECT. So we have demonstrated two cases that sometimes it can be due to underlying medical illness and can be life threatening if not addressed in time, but not always this can be the case, and sometimes this is not always that the poor treatment response are difficult to treat, and liaison with the medical team is important for optimizing that medical. Thank you.
Any questions? I think we have 2 minutes. So long-term outcome. It depends actually. If catatonia is due to some other illness, like in this case, both the cases, one was bipolar disorder, other was SLE and bipolar disorder. Bipolar disorder, it's difficult to say whether it was primary condition or it was secondary to SLE. In these cases, this was the early onset of bipolar disorder, so it's likely to contribute. It could be a single episode catatonia that could carry. Sometimes the patients of schizophrenia can present the catatonia symptoms. Prognosis would be all.
Thank you.
After those interesting presentations, I think very good evening from Department of Surgery, Unit 2. We're going to present an interesting case of hypoglycemia. Now, we all know that bariatric and metabolic surgery leads to a good weight loss, but very few of us know that it leads to a very remarkable impact on diabetes. And sometimes these mechanisms which impact diabetes overshoot and lead to intractable hypoglycemia. And we're presenting this case not only because of this rare problem, hypoglycemia, but also an array of complex medical and social surgical challenges which made it a very rare and interesting case. So the case will be presented by Dr. Ravi, Senior Resident in Surgery, and discussed by Dr. Vitish, Fellow in Bariatric Surgery. Ravi, please.
So the case today we are going to discuss is a 49-year-old lady with severe obesity. She had a very complex and long surgical as well as medical history. She was diagnosed with carcinoma left breast in 2008, for which she got treated. Following which she was doing good, but she had this severe obesity, for which she underwent surgery. And the surgery was done in a private hospital in Kolkata. The surgery done was mini gastric bypass. At the time of surgery, had a BMI was 61 and the weight was 155 kg. She was diabetic, requiring insulin, OSA, for which she required CPAP, and asthma, for which she required inhalers. After surgery, surprisingly, she had the weight loss of only 15 kg over the next 6 months, and her comorbidities didn't resolve. So all these comorbidities were still there after the surgery. And rather, she had developed new symptoms like pain upper abdomen, food intolerance, and hematemesis. For these problems, she underwent evaluation. While undergoing evaluation, during the endoscopy, it was found that there is a large marginal ulcer at the gastrojejunostomy site, for which medical management were tried, but it failed. And so the patient was planned for RYGB, considering it will solve the problem of marginal ulcer, as well as it will further enhance the weight loss, as it has only 15 kg of weight loss after the first surgery. So she underwent RYGB in a Roux-en-Y gastric bypass. So this is a bariatric. So this is a Roux-en-Y gastric bypass, is a bariatric surgery. She underwent Roux-en-Y gastric bypass in Hyderabad. At that time, her body weight was 140 kg and BMI was 55. She was all these comorbidities were still there. After surgery, she had significant amount of weight loss, that was 45 kg, and her BMI dropped from 55 to 37, and all her comorbidities resolved. But now she developed a new symptom, that was she had neuroglycopenic symptoms of, hypoglycemia off and on she started developing. For this, she required multiple hospital admissions, and her first hospital admission was in the ICU just after 15 days of surgery. While she was struggling with hypoglycemia, she was diagnosed with a new problem, that was internal hernia. In internal hernia, what happens is small bowel enters into a mesenteric defect and gets strangulated here, that is stuck there, and it causes the features of intestinal obstruction, which may present as distension, vomiting, and pain abdomen. For this condition, she was managed laparoscopically, where they reduced the bowel. The bowel was not gangrenous, it was healthy, and they revised the jejunostomy site, and they changed the limb lengths of the biliopancreatic limb and the Roux limb. And after the surgery, she had a weight loss of further 20 kgs, but the symptoms of hypoglycemia were still there. And again in February 2019, she had pulmonary embolism, which required ICU admission for management. And still she was having this hypoglycemia there. In March 2020, she had hematemesis and was diagnosed to have large marginal ulcer again, but this time she was managed with conservatively with proton pump inhibitors, and she recovered well. She came to AIIMS in January 2023 with complaints of symptomatic hypoglycemia, often hematemesis, and food intolerance in the form of vomiting after having any solid or semi-solid diet. At the time of presentation, her body weight was 81 kg and BMI was 32. During the hospital stay, she required continuous infusion of dextrose because of hypoglycemia. And here we can see her blood glucose readings. They were all fluctuating between 20 and most of the time between 50, and it never crossed 60. During the evaluation, we took endocrinology consultation, for which we did extensive investigations, which included insulin and C-peptide. These were at the lower limit of the normal value. So this raised a doubt of factitious hypoglycemia, for which we took psychiatric consultation, and ultimately we were able to rule out after detailed history and observation that this is not a factitious hypoglycemia. Then we did a proton PET scan to rule out mesidoblastosis, as this is a common cause of hypoglycemia in this kind of patients. In that, While discussing, there was a doubtful lesion in the tail region, which was most likely physiological. And to rule out that, we did MRI, and further CCT and gastrographic study was done, for which I would like to call upon my radiology colleague, Dr. Mayur, Radiology SR, to discuss the CT and MRI.
A very good afternoon to everybody present here. Myself, Dr. Mayuk, SR in Radiology. I shall be discussing the few radiological findings in this case. Regarding this case, regarding the important findings in CCT abdomen done on 11th of January, here there are coronal images of the abdomen. Here we can see that there is evidence of stenosis at the gastrojejunostomy anastomotic site. These are sagittal images which are showing the same finding of GJ site anastomotic stenosis. This is the anastomotic site which appears very small and stenosed. These are CCT abdomen images which are showing that in spite of the anastomotic stenosis, there is free passage of the liquid contrast material to the distal small bowel loops. Keeping the stenosis in mind, a gastrographin solo was done on 17th of January. Here also we can see that the gastrographin, which is a water soluble contrast material, it is freely passing across the gastroesophageal junction into the stomach and then further across the GJ anastomotic site into the small bowel loops. In the meanwhile, to evaluate for the suspicious uptake in the pancreatic tail region, an MRI was done for the patient. Few relevant positive findings from the MRI done. Here we can see that multiple tiny equally sized calculi are present in the GB, sized of cholelithiasis. Also in this patient, the CBD was mildly prominent. The diameter was about 8 mm. But no abnormal mass lesion present in the pedioampullary region. The MPD is also normal, so this is likely attributed to old age. Now focusing upon the pancreas, here are a few representative images from the tail region of pancreas. This one is the T1 weighted image and this is the T2 fat site weighted image. Here we can see that there is no abnormal focal signal intensity region in the pancreatic tail. Further contrast enhanced MRI was done for the patient. This is the pre-contrast T1 fat site image. This is the pancreatic phase image post-contrast and this is the venous phase image post-contrast. Here we can see that there is no abnormal focal contrast enhancing region in the pancreatic tail. Thank you. These were the major radiologic findings in this case.
So after ruling out pancreatic causes of hypoglycemia, we were left with a patient who had just intractable hypoglycemia, and the cause was probably the dumping syndrome or the overcorrection of the diabetes after Roux-en-Y gastric bypass. Along with this, he had other associated problems like gastrojejunostomy site narrowing, marginal ulcer, which bled once whilst he was admitted in the hospital, which was managed by injection ADR and Hemlock clip application. Here we can see the ulcer at the gastrojejunostomy site. So after this, we decided to operate on this patient, and the surgical options we had was revision of the gastrojejunostomy site. And this surgery could have corrected her two problems, that is stenosis at the gastrojejunostomy site and the gastric ulcer. But if it was dumping syndrome, then it could have worsened the signs and symptoms of dumping syndrome. So after detailed discussion, we decided to go ahead with Roux-en-Y gastric bypass reversal to normal anatomy. This was not a straightforward reversal of the Roux-en-Y gastric bypass to normal anatomy, as this patient had undergone previous multiple abdominal surgeries, so we expected a dense adhesion, and she also had the history of pulmonary thromboembolism. In the preparation, we did arrange adequate amount of blood and blood products. Perioperative prophylaxis was adequately followed, and intraoperative endoscopy was arranged. And preoperatively, we discussed with our gastroenterology colleagues for the intraoperative assistance. So let's understand what is Roux-en-Y gastric bypass and what do we do in reverse. In Roux-en-Y gastric bypass, we divide the stomach, making a very small gastric pouch like that. This is the gastric pouch which has been created after division of the upper part of the stomach. And then we divide the jejunum at 70 centimeter from the duodenojejunal flexure. And then the distal part of the jejunum is brought up and made a small anastomosis with the gastric pouch. And this proximal part of the jejunum is anastomosed to the jejunum. This is called jejunal anastomosis. And this limb, that is called Roux limb, is usually kept around 100 to 150 centimeter, and this is about 70 centimeter. And if we look at the reversal, so we have to make this to a normal continuity. So this essentially consists of 3 steps. First is resection of this part, that is called resection of the gastrojejunostomy, and then making anastomosis between this gastric pouch and the remnant gastric stomach, so that the food can enter from this part to the remnant part. And then we have to resect this part, that's called Roux limb. So we resect it just before the jejunostomy site. Coming on to the video. So in view of dense adhesion, we gained access using the optical trocar to avoid the bowel injury. And we can see there is adhesions. So we use the lever retractor self-retaining Nathanson to hold the lever, which is usually bulky in these kind of patients. And now we are doing adhesive lysis around the gastric pouch and the remnant here to identify the gastric pouch and the gastrojejunostomy site. So this is the gastrojejunostomy site, which was further confirmed by the endoscopy. And endoscopy also helped us to locate the gastric pouch, precisely because they are usually buried in the adhesions and makes it really difficult to find where the gastric pouch actually. And now here we are doing a bowel walk and at the Roux limb. Here we can see the stipple lines of the previous surgery she has undergone. One more stipple line will be there, which is of the gastrojejunostomy, the first surgery she has undergone. And on further moving down, here is the currently existing jejunostomy site. Now we are walking on the common channel of the bowel to assess its length. This is very important to assess the common channel length for the postoperative outcome, so that the seed doesn't lands up in a short bowel syndrome. And in this patient, it was 550 centimeter. Now we are trying to assess the biliopancreatic limb, and this was 50 centimeter. This is the duodenojejunal flexure. Now we are trying to make a window around the jejunal end at the gastrojejunostomy site, and here we have divided the jejunum. Now we are doing further adhesive lysis to mobilize the gastric pouch and separate it from the remnant. And here we are resecting the gastric pouch with gastrojejunostomy, the actual affected site of stenosis and ulcer. And here we are doing further adhesive lysis between the gastric pouch and the remnant to have adequate space and length for the anastomosis between the gastrogastric anastomosis. To make it tension free, we are taking it posterior layer. We are switching the posterior layer to just keep the anastomosis tension free and more stable. Here we are assessing the anastomosis, and now we are making gastrostomy on the gastric pouch using a harmonic ultrasonic device. Now we are making gastrostomy using electrocautery hook at the gastric remnant. Now we are finding purple endostapler, which consists of 3 rows of staple lines on the both side and an inbuilt cutting device which cuts between the 2 rows. And here we are closing the common opening of the gastrogastric anastomosis using a delayed absorbable suture. And now we are putting normal saline to check for the leak while doing the endoscopy. The air used for the endoscopy is used here as the method to check the leak. And now we are making mesenteric window on the jejunal end of the jejunostomy site. And here we are dividing it using the stapler. And then we resected this roux limb staying close to the bowel. And this is the complete resection of the roux limb. As she had long common channel, so we decided to resect the roux limb. And now we are retrieving the specimen of the gastrojejunostomy resected site and the roux limb. This is the resected roux limb which is being retrieved. In the postoperative period, was uneventful. She was allowed liquid diets on the POD1 and was discharged on postoperative day 7. At the 6 months of follow-up, her symptoms actually improved significantly. Symptoms and frequency has improved significantly. She has not required any hospitalization, and her current weight is 76 kg. At the time of surgery, it was 81 kg. So she has not gained any weight. Actually, the problem with reversal surgery is one of the problem is weight regain, and so far she has not undergone any weight regain. And her current blood glucose level is fluctuating between 50 to 100, but the severity of symptoms and frequency has significantly decreased. Now I would like to call Dr. Vitis for the further discussion of the case.
Good afternoon, everyone. I'll be discussing this case. So, as we all know, Roux-en-Y gastric bypass is a time-tested procedure and it has proven long-term safety and efficacy. And with more than 70% of the patients maintaining more than 20% of total weight loss, even at the end of 10 to 15 years. Apart from the weight loss, there is a remarkable impact on type 2 diabetes mellitus with as this paper in NEGM showed more than 70% remission, and recent series show more than 70 to 80% remission over long term. So, however, the impact on diabetes can overshoot sometimes. So, some of the problems, long-term problems associated with RYGB include persistent hypoglycemia, intestinal obstruction or internal hernia, marginal ulcer or gastrogastric fistula. Surprisingly, our patient had all of these problems: hypoglycemia, internal hernia, and marginal ulcer. So, just a brief discussion about evaluation of post-bariatric hypoglycemia. There are some causes. One of them is nocidioblastosis. The incidence is around 0.1 to 0.3%. The pathophysiology is elevated insulin and C-peptide levels along with postprandial hypoglycemia, and it is a subset of non-insulinoma pancreaticogenous hypoglycemia syndrome, which is called NAPHS. Other causes late dumping, which usually occurs 1 to 3 hours after a meal, and it is characterized by neuroglycopenic symptoms including fatigue, weakness, confusion, and or autonomic and adrenergic reactivity, which include perspiration, palpitations, and tremor. So, the important thing in the evaluation of post-bariatric hypoglycemia is to rule out any pancreatic cause of hypoglycemia. And in all the pancreatic causes, the levels of insulin and C-peptide are raised. So, in our patient, the insulin and C-peptide were normal, so we were able to rule out any pancreatic cause along with the normal imaging. The basic pathophysiology behind the post-RYGB hypoglycemia includes increased GLP-1, increased incretins due to rapid delivery of nutrients into the distal bowel or small intestine. This increased GLP-1 results in stimulation of insulin release and inhibition of glucagon release, which results in lowering of blood glucose. The other theory which has been postulated is decreased insulin clearance associated with alteration of bowel anatomy following RYGB. So, just a brief discussion about the evaluation of the steps about the post-bariatric evaluation of steps of post-bariatric hypoglycemia. So, when the hypoglycemia is confirmed by symptoms and blood glucose of less than 54, it's the hypoglycemic disorder is confirmed, and in bariatric patients, most commonly the hypoglycemia starts after 6 months of surgery, and which is then called as post-pediatric hypoglycemia. The initial treatment usually includes dietary management and drug therapy, which includes acarbose, diazoxide, and octreotide. However, the problem is that most of the patients require discontinuation due to persistent symptoms or adverse events. The surgical options for management include gastrostomy tube feeding or partial or total pancreatectomy. Tube feeding is not feasible for the long term, and partial pancreatectomy results in, and patients undergoing partial pancreatectomy have recurrence of symptoms, and total pancreatectomy results in brittle diabetes and increased perioperative morbidity. So RYGP reversal is the best treatment option in medically refractory hypoglycemia following RYGP. So this shows how hypoglycemia resolves following reversal of RYGP. As I discussed earlier, rapid transit of food to distal intestine, increased GLP-1 levels, and subsequently increased insulin result in hypoglycemia. And following reversal of RYGP, the transit of food is slowed down, the spike of GLP-1 is reduced, and thus the insulin levels are also reduced, and which results in decrease of resolution of hypoglycemia. So coming to the other indications of reversal of RYGP apart from hypoglycemia, the commonly include conditions are food intolerance, malnutrition, hypoglycemia, chronic recalcitrant marginal ulcer, or excessive weight loss. And other indications include GJ stricture and internal hernia. So revision or reversal surgery usually addresses a problem that has failed non-operative management. It is associated with a higher surgical risk due to chronically inflamed thicker tissues and altered blood supply of the tissues. The results are difficult to predict, especially weight management following reversal of bariatric surgery. So these are some of the large series which show that the revision surgeries are usually associated with a significant complication rate. And for example, these authors showed around 30% 30-day complication rate, including 5 patients with leak and 3 patients requiring blood transfusion. And another review showed that the long-term problems include weight regain and presence of gastroesophageal reflux disease, and the incidence of leak and bleeding is higher following revision surgeries, which is less than 1% in primary bariatric surgery. An important point to note is the presence of deteriorating or persistent hypoglycemia, and around 5% of patients may have that following reversal of RYGP. This was another paper, a recent paper, a large series by Dr. Kelvin Higa, and five patients in these series had hypoglycemia, and all of them had resolution of hypoglycemia following reversal of RYGP. So coming to our case, it is the first count of reversal to normal anatomy following a revision RYGP after a primary OAGP. So first patient had undergone a OAGP procedure, then revised to RYGP, and then we revised this revised RYGP to a normal anatomy. So this has not been reported yet in published literature. All the possible complications which could have been there were present in our patient, including the bleeding marginal ulcer, GJ stricture, persistent hypoglycemia, pulmonary embolism, and LRTI. It was more technically challenging than following primary reversal of RYGP. There were increased intra-abdominal adhesions near pouch and enterostomy, and the more dramatic variation of anatomy from the normal bowel anatomy. So accurate measurement of bowel lengths was pivotal in guiding our plan. The long common channel length of 550 centimeters allowed us to excise the roux limb, and this excision of roux limb avoided another anastomosis and decreased the perioperative risk. And for excision of the GJ anastomotic site, the dismantling should be done below the GJ first to so that the pouch can be mobilized completely and with ease. So to conclude, revision surgery should be done at a high volume center. Reversal of revision procedure to normal anatomy is technically feasible, and it can be considered if the need rises, especially in this case as she had intractable hypoglycemia, marginal ulcer, GJ stricture. Thank you so much.
Thank you, Vitesh and Ravi. I think this complex case required not only surgical expertise, but I think a lot of teamwork from our medical colleagues, especially from endocrinology. Dr. Jasheep Gupta was constantly in touch with us, and Dr. Shalimar. I would just request for the comments for this case.
Thank you, sir. I think this case from endocrine perspective was a great learning for us also. Basically, in this one, with post-bariatric surgery hypoglycemia, the main possibility remains the dumping syndrome. So usually classical hypoglycemia is seen after 1 to 3 hours between taking meals. This patient was odd because the patient was having hypoglycemia fever and it was like whole throughout the day. It was not specifically related to meals. That is why the dumping syndrome was not kept possibility from endocrine side. The second possibility usually comes on nesidioblastosis. So nesidioblastosis, what happens is C-peptide is not expressed. I think we don't have values presented, but in this case, most likely C-peptide was actually, I think, expressed. So multiple assays from our side has seen, because there are constantly, we are getting consultations over a couple of weeks. So everyone, and after each discussion we used to land up in factitious because insulin was elevated and C-peptide was suppressed, which was fitting into factitious. But the thing is that factitious is very difficult to prove, even with the help of psychiatric colleagues, because we do have cases when we involve the psychiatry consultants. So it's very difficult to prove the factitious one. From the management perspective, again, the classical learning is that it is a nesidioblastosis and you go for a subtotal pancreatectomy if the conservative measures don't fail. Subtotal or the total pancreas, which is again a moribund procedure. So I think this was the second learning, that seeing the reversal of ROX and Y and then seeing patient improving, I think this is a second point which is not well discussed in the literature. So these were the couple of learning for us also. Thanks.
Thank you for your comments. I must say at this point that the decision to operate and reverse was taken after a lot of deliberations, including some well-known international experts. They said just reverse it. There's no other investigation possible, no other management possible, and then look for, so we're lucky that we had a good outcome in terms of not only surgical complication avoidance, but also hyperglycemia. I think comment from Dr. Shalimar, who we always take help, is like a team of bariatric specialists. So come in.
So I think it's from an endoscopist point of view, our role is quite limited. We're only called up when actually a patient has bleeding. So it's like we can go in through a scope, and as what happened in this patient was, we could take care of that bleeding. But then the other complication which we can manage endoscopically is like a stricture. If it is there, we can do some amount of dilatation. The third is our role comes in when a surgeon wants us to know, can we guide us where the position or where that over here the gastric stump was. So they want. So that comes the role. Though the endoscopic or the endobariatrics is another thing which is coming up, which is a separate point of view. But then this is where we chip in to help in the patient's management. And I think this patient was very, very complicated. It's very simple to say and show in slides what happened when you manage such a sick patient. It's really a very difficult scenario. And I must tell you, day-to-day decisions are not very easy in taking such patients. Thank you.
Thank you for your comments. Any questions from the floor? Thank you. I think she was on insulin, and the impact of diabetes is very dramatic. Most of the patients get discharged without any medication. If we write medication, they will go into hypoglycemia. So the classical teaching, our protocols say don't give any anti-hypoglycemics because the response, endocrine response is dramatic. The food empties faster and the GLP-1 rises. And we've proven it in our own setting. We've published on this about the detailed mechanisms of resolution of diabetes. But yes, sometimes this happens. Although not rare, is uncommon, but the combination of factors, marginal ulcers, stenosis, and the hypoglycemia, and the fact that she had two bariatric surgeries, and then 2 more surgeries makes it a really, a case worth presenting. Thank you so much for patient listening. Thank you. And I also acknowledge the support of radiology and anesthesia for this case. Thank you.